Do you suffer from stomach aches and bloating and painful bowel movements, especially during your period? Bowel endometriosis is one of the most common extrapelvic areas for the disease. In this video, we'll discuss bowel endometriosis with the Indian Endometriosis Center's Dr. Abhishek Mangeshikar. This is an awesome video from one of our Instagram lives. I'm Dr. Sallie Sarrel, a pelvic physical therapist and person with endometriosis, and we're excited to have you along to learn about bowel endometriosis. Hello, everybody who's out there. We are talking about poop today with Dr. Abhishek Mangeshikar, who I see he's joined. And we're gonna in. There you are. I could remove my poop head.
That's hilarious. Hi.
Nice to see you.
Good to see you too. Well, good morning for you.
Good morning. Good evening to you. Tell everybody what time it is there.
It is 7:30 on the dot right now.
7:30 on the dot. So Dr. Mangeshikar is nothing but if not punctual. Doctor, this may be not our Facebookers because they met you during your webinar, which if anybody wants to see Dr. Mangeshikar's webinar, it is on our YouTube channel and it is fantastic. And so if you're trying to educate yourself about bowel endometriosis, please do start with this webinar. But doctor, can you introduce yourself to everybody?
Yeah, hi everybody from wherever you're tuning in. I'm Abhishek Mangeshikar. I'm a gynecologist based out of Mumbai in India. I specialize in endometriosis and pelvic pain and the surgical treatment of that. I also lead a multidisciplinary team in the treatment of endometriosis and pelvic pain. And I'm here today to talk to you about bowel endometriosis and the wonderful world of feces that come along with bowel endometriosis.
Right. So this all began because we made a post with a meme of you that we really liked from the webinar. And we talked about, does colonoscopy play a role in diagnosis of bowel endometriosis? Does colonoscopy play a role?
Yeah, that's really interesting because just I think last week I had a patient, Indian patient who flew in from Texas, and she had a bowel nodule, which I saw on her scans, and her general gynecologist there said, I'm only going to do a cystectomy, but I'm going to take photographs for the doctor in India to deal with. So fortunately, she didn't go through with the surgery there and just had the one surgery here. But she insisted on a colonoscopy before, so we arranged that and got it done. And even though it was a significantly large nodule in the bowel that was causing stenosis of about 40% or 50%, the colonoscopy didn't even pick up the narrowing of the lumen because they use distension. So it pushes the bowel wall away. So even what I've read in the literature, when colonoscopy does pick it up, is those rare cases of bowel endo that actually make it through the submucosa or just indenting the mucosa, which is the inner layer of the intestine. And or if there's a huge, almost subocclusive disease where they cannot even counteract the distension with the media they use.
Right. So what I see a lot is that the GI or whoever is doing the colonoscopy takes pictures, like sort of like to say to the patient, here, your bowel is fine. What are you complaining about? And then when you take those pictures to the endometriosis specialist, they see that the bowel is a little bit narrowed in the picture, or they see, right? And so it's this subtle thing that the GI doesn't even pick up on. And so we had another post this week on IBS versus endometriosis. How
Yeah.
do you, now I feel that most IBS in the people who end up in my office really is endometriosis that's misdiagnosed. But how do you help guide people? What's the difference between the two?
Yeah, so I've actually pulled up a slide of that, which we can't share, but I'm going to read that out to you. So what is used for IBS diagnosis or irritable bowel syndrome is the Rome 2 diagnostic criteria, which is you need 2 out of 3 features for at least 3 months. It does not need to be consecutive, but any abdominal discomfort or pain that has these features. One is it's relieved with defecation. 2 is the onset is associated with a change in the frequency of stools. And 3 is the onset is associated with a change in the appearance or the form of stool. And symptoms that are supportive of this is abnormal frequency, which is more than 3 a day and fewer than 3 a week. And of course, you saw, I think you guys did a post about the Bristol stool chart, which, lumpy or hard or loose and full of mucus or watery stools. That is also supportive for this diagnosis. And the abnormal stool passage, which is straining, urgency, or feeling of incomplete evacuation or tenesmus, and the passage of mucus and bloating or the feeling of abdominal distension. So, a lot of these symptoms sound very similar to what someone with bowel endometriosis will present with. And it is difficult to base the diagnosis only on history, but you would see that maybe the symptoms would get worsened in a catamenial manner. This is not an absolute rule, but they may give you this history that it does get worse at the onset of the menstrual cycle. And also, for me, I think the imaging is absolutely, because I don't think it's acceptable to miss a bowel nodule on imaging, whether it's ultrasound or MRI.
Our dream, in addition to having you in 2022, is to bring in, there's a team from the Mayo Clinic and a team from NYU that's doing sort of advanced imaging for endometriosis, because I don't think the average radiologist and the average gynecologist understands imaging when it comes to bowel endometriosis. And I do want to really encourage, Instagram is much more casual. We're going to have Dr. Mangeshikar back to be on Zoom at some point, because then he could share all his slides. But his webinar that's up on our YouTube page has a large portion on imaging, and you can go look at him actually showing how to read imaging. I see there were a lot of questions how this all began was, what is the shape of poop say about adhesions or endometriosis or IBS, which sort of led to me doing that Bristol stool chart. I tried to make it, I'm living at the beach for the summer, so I tried to make it out of sand, but it was just, that turned into a disaster. And then 10 people were walking by telling me about what their poop looked like and whatever. I had to use a real chart. But what does the shape really mean? If it's long and ropey or if it's only liquid, what are those indicate to you?
Yeah. So if the couple of red flags that stand out when a patient is giving you history about the passage of stools, if they're chronically constipated or they have to strain a lot, or if there's constipation followed by diarrhea. So that to me is telling me that there is an obstruction of the stool, and because of the obstruction, there's irritation of the mucosa, which is causing the loose stools and the passage of mucus. And also, if they have to strain a lot, it becomes either really long and ropey, or like, like scat, like hard pellets that are a very common sign of constipation.
The Sarrel family name for that is nanny goats,
Oh, yeah.
right? And so, we always talk about how endometriosis is probably genetic, but we didn't know. And so I can remember being like an 18-year-old, very sick, and then saying something to my grandmother, and she'll be like, "Oh, that's just nanny goats." Except my mother and her sister, there were 7 years between, and nobody used birth control in the 40s. So it's interesting to me that it was so normal for her to say, "Oh, you get nanny goat, whatever." And then I didn't go to a doctor for like 10 years because both my mother and my grandmother said it was normal. What, like, a lot of people are asking, what about pain when you poop? And I'm a pelvic physical therapist, and we could certainly talk about that. But what is pain when you poop sometimes indicative of?
Yeah, so dyschezia, or the painful passage of stools, is very significant also as a symptom, because there's such a tremendous amount of force that has to be used to evacuate the bowel to overcome the obstruction of the nodule. So I think a lot of people find the term nodule a little difficult to get a grasp of. So if you think of the intestine as a tube, with the outer layer is made out of muscle, smooth muscle, and longitudinal muscle. There are many layers, but just the outer layer of muscle, and the inner layer is kind of like the tunnel where the feces pass through. So the disease is like a hypertrophy of the muscle. So it's really kind of just occupying the space of the lumen, which is where the stools would pass through. And if this muscle is really big and hypertrophic, it's not going to be, you're going to have to use a lot of force and strain the pelvic floor muscles to be able to overcome that obstruction. So I think that causes a lot of pain. And there's actually a really interesting paper about where they studied, there was involvement of different nerve plexuses in the bowel, in the endometriosis specimens that went for pathology. So a lot of them looked at the intestinal cells of Cahill and the Auerbach's and Meissner's plexi, and how much nerve involvement there is by bowel nodule. So if it's a superficial nodule, there is not so much nerve involvement, but if in the muscularis, it's the Auerbach's plexus, and if it goes into the submucosa, that's where it affects the Meissner's plexus, which is going to lead to a lot of symptoms. So this would tell you the symptoms of how deep the nodule is going, just based on that. I mean, this is early research, but I think it was a very interesting paper.
Oh, do you think you could, you should DM me that paper, and hopefully we'll be able to get that out to everybody. We'll get that link out to everybody. So, because that sounds really fascinating. And I think, like, I mean, just in general, I feel like the research of these nerve plexuses and everything is really the key to why endometriosis causes pain for some and not for others. Because I was speaking with on Thursday, she's a hypermobility expert, but she reads chronic pain literature all the time. And it's really, I don't think it's as simple to say it's either peripheral or central nervous. I think there's something that ticks off everything. So when we talk about if it hurts when you poo, or I like to say poop, I see the internationals are all saying poo. But when we talk about that, I want to mention that a couple of things happen to your pelvic floor. The first is that your pelvic floor's job in life has this protective mechanism. And so if it's hurting when you poop, one of the first defensive mechanisms it's going to have is to protect you.
So if you think about, if you reach for a stove and it was hot, you recoil right away. And so that's really what happens to your pelvic floors. And I believe if people really go back through their history with bowel endometriosis, they had pain all along. I was like a constipated 9-year-old. I talked to our very good friend, and she had, who's done a lot of work with the summit, and she has a 13-year-old now who's had stomach problems since she was 8, and the mother has terrible bowel endometriosis. So I think that those patterns are set up a long time. It may not be as inflammatory until you get your period, but you know, the lining of the gut, it's not just like you're a kid who eats gluten. I think there's way more to it than that. And then what happens is there's a muscle called pubococcygeus, and pubococcygeus runs from one part of the pubic bone and slings around and runs to the other part of the pubic bone. We'll make a reel. Reels are our thing now. And this muscle sort of allows the anus and rectum to open and be in the right position for poop to fall out, right? And so people like that squatty potty because it helps this particular muscle adjust. I happen to like telephone books under the feet on the toilet over the squatty potty because it's a little easier on the hip. And if you have the hernia, which most of my patients do, the squatty potty can be tough on the inguinal canal. So the other thing to think about is if you have pain just as the stool exits, there's another grouping of muscles called the transverse perineal muscle. And that actually allows everything to open so poop can leave. And so when a couple of things happen, if you have bowel endometriosis, these things go into spasm. If you have any bladder upregulation, these things go into spasm. If you have IBS, these things go into spasm. And here's my really big thing. If you have anxiety, these things go into spasm. And then if you have anxiety because no one believes you have the other three things, these things go into spasm. So, doctor, how would you tell the difference between, like, which is first, chicken or egg? Because you have a nice physical therapy team there in India. And by the way, Dr. Mangeshikar, people travel to see him because sometimes care is much more accessible in India than in the United States. So that's one of the reasons why we want to bring him on here. I'm sorry that care has gotten that way, but it's very true. So how do you tell the difference between what's what when it comes to bowel pain in your clinic?
Yeah. So like I said, it's about listening to the symptoms and kind of taking it in and building a scenario as I'm listening to the story. And for me, it's a cumulative accumulation of the examination and my own ultrasound as well, where I'm looking for disease. So stuff like the symptoms we've discussed are going to tell me, okay, I need to look at the bowel. So when we look at the bowel, I usually think of, there's two types of bowel nodules in general. So one is like a posterior adenomyoma that is right at the back of the cervix or the isthmus of the uterus, or which is called the torus utrinus, which may or may not involve the vagina, and it's where the rectum, the mid-rectum is usually stuck to. And the nodule may be growing into the rectum. There. So those are like type 1 nodules. And then you have the nodules that are singular, that may be higher up, maybe in the sigmoid or the cecum or the appendix or the ileum. And those are the other type of bowel nodules, not so, as common as type 1. Yeah.
So your type 1, that first of all, we have a very good video. We got to get you the password. In the Endo Summit, in the video library, we have a video of Dr. Vidali operating on that. But he actually invented this technique, which he calls the maneuver. And when he's in the operating room, he couldn't come today. But when he's in the operating room, he goes, time for the maneuver, right? Just a very specific technique for that lesion, because he believes that what people call adenomyosis or people call adhesions, and they have horrible pain from sex with and bowel movements, is typically from that lesion. And it's something you can really deal with. Yeah, I just wanted to add that because you know, when you operate, we're not excited you have these things, but we're excited we can help you, right? Do you,
Yeah.
and oftentimes that one's a little harder to see on imaging. Are you able to pick that up on imaging? Because usually he has to do that on exam with the ultrasound.
Yeah, you can. So that nodule is, like you said, perfectly, you can palpate it on vaginal exam. And it's also easy enough to see on ultrasound if you can get uh, posteriorly behind the cervix. If you can just put the probe right behind the cervix, it may be a little painful. So you have to tell your patient, well, don't say the word relax because that really just annoys everyone, but you got to tell them how to relax. So I say, keep your pelvis on the table, don't lift it up, and let your knees go floppy. And that's the way to kind of relax the pelvic floor. And of course, do it slowly because these patients have a lot of pain, and use lots of ultrasound gel.
Okay,
Maybe
so
even local
I am a
anesthetic.
pelvic PT. I've been
Yeah.
a patient for, I'm very old, so I've been a GYN patient for at least 30 years. Tell everybody again how to relax your pelvic floor, because you're the first doctor who's ever put it in words here and on your webinar. And I want everybody to know what to do when they go to their own doctor. Say it again.
Okay, so the trick is not to lift the butt off the table. So let it stay flat on the floor or on the examining table, and let your knees go floppy to the side. Mm-hmm.
It's so important because it also helps you not have that speculum fear, although a lot of endometriosis surgeons don't use speculums. But if we can't get a good exam for lots of reasons, then it becomes really hard to work with you. So talk a little bit about that sigmoid lesion.
Yeah.
And what how symptoms of that might be different than the type 1 lesion.
Right. So the type 1 lesion, like you said, we're not excited about it, but it's great because you know that as soon as you finish your surgery, that the patient's relief is going to be almost immediate. Well, she can't have, if you do a vaginal resection, she can't have intercourse for about 6 to 8 weeks, but after that, that pain is gone. So that's really satisfying for us as treating practitioners. And yeah, so the lesions higher up on the sigmoid will be, one is you can't see those on ultrasound because you're, well, at least I can't, your probe can't reach that far for lesions on the sigmoid or higher. So then MR imaging is the weapon of choice. I have seen some groups change to the linear abdominal probe to visualize the sigmoid higher up, but I don't know anyone who can do that, and at least in India, and I can't do it either. So I do rely on MR imaging for any bowel endometriosis or any symptoms suggestive of bowel endo that I encounter. And I think the sigmoid lesions present with a lot more bloating, especially there will be a very left-sided pain that is described because the sigmoid is usually got a whole bunch of congenital or acquired adhesions on the left abdominal side wall. So that is the descending colon where is the sigmoid that is involved most commonly.
So we had a Clubhouse. For people that don't join us on Clubhouse, you should. But we had a Clubhouse, and Endo Girls blog was talking about their bowel endometriosis. I think she's on, but one of the things she said was that she would try to go to the bathroom, and almost to the point, it would hit a certain point, like the poop would hit a certain point, and she would almost be holding the walls of the bathroom, which I got a lot of comments about how people, when they have pain, when they poop, they grab the walls of the bathroom. I happen to have grab bars in my bathroom that I have held on for dear life. And as the stool would pass this one spot, it either would be so much pain, she'd be sweating and shaking, or she'd pass out, which I think is interesting when you talk about those little nerve plexuses. And then she would be able to, if it got past that spot, she would be able to go And again, a lot of times it would end with diarrhea because the body would be working so hard to get past that spot. And I'll tell you, we use Endo Girls blog as the example for that, but I could tell the exact same story. And we actually kept like a very large dog bed in the bathroom because there would be times I would have to lay down. I didn't want to lay on the bathroom floor until it passed this one spot. And we're normalizing this. That's what scares me, is that we say people have pain. For years, we normalize pain like that. Do your patients tell stories about what it's like for them to actually try to poop? Because this is Instagram. We could be a little more informal.
Yeah. So that's really interesting, because I encourage when somebody is giving you their history, so I encourage it to be in your own words. You don't have to look for the medical jargon. Just, describe it how it happens to you, how it feels. If it feels sharp and stabby, or if it feels like death by 1,000 cuts, then, that's what I want to hear. I want to put the translation of the symptoms in by the patient's own language. And I find that really useful. And then talking about blackouts, that is something that Mark Possover described really well. So he likened it to, he's like, when there is an overstimulation of these plexuses, it's like getting punched in the gut by, I don't know, like Mike Tyson or something, when you hit the solar plexus, and that pain, that overstimulation of the nerves is so overwhelming that they pass out. So the same thing can be reproduced if you are very rough with a pelvic exam, and you can elicit almost the same response where the patient can black out during the examination. So the same thing would happen if stool was passing through the bowel, and there was a huge amount of pressure being applied to stimulate these nerves or hyperstimulate these nerves, and produce the same result of losing consciousness.
It's so fascinating because I had a solar plexus injury in my 20s when I was an ocean lifeguard, and I had a surfing thing on a rescue. And for years, they blamed my bowel pain on that solar plexus injury, not realizing the disease was, you can have things happen to both. So fascinating that you talk about the blackouts and that, because patients don't like to tell people that. But if you ask, I would say about 50% of my patients have experienced it at least once. And so it's really, I love like being able to do something informal like Instagram. So, I wonder, how do you tell I can tell you what Dr. DeLumbo would say, right? My adhesion guy, but how do you tell the difference between adhesions and actual bowel disease, or does it not matter to you?
So it truly depends on whether the adhesions are congenital or acquired from previous surgery versus if there's a pathology causing it. So I think the symptoms of, so at least endometriosis related adhesions are going to be much worse than, unless, of course, if you're talking about extreme adhesions where there's an incarceration or something like that of the bowel. So yeah, apart from those, when you look at your, run-of-the-mill adhesions from surgery or just congenital or an infection perhaps, those will usually not have such pronounced symptoms. And again, I keep coming back to it. For me, it does come down to the imaging a lot that I need. I know you can't see everything on imaging, but for significant bowel lesions, we are pretty accurate, in the high 90s on diagnostics about that.
I think it depends who's reading the imaging a lot of times too. So like in our clinic, it's not just the bowel surgeon, it's not just the endometriosis surgeon that reads the imaging themselves, but it's also typically the bowel surgeon that reads it too. And that's for a lot of reasons, but a big reason is surgical planning, which Dr. Mangeshikar discusses at length in his video on our YouTube. It is a fantastic webinar. He did that with extra pelvic, not rare. I don't want anyone to miss out on that. But Dr. DeLumbo would say, because I've had this conversation with him, when it's adhesions, he really asks patients when it hurts. So sort of if it hurts when you poop, there's not a lot of things that you can tell, but he seems to feel that if it hurts after you eat, sort of as peristalsis begins, he suspects adhesions more. Do you go into that, or you don't really think that? Some doctors know they're going in, they don't think to make that delineation.
Yeah, that's interesting. For me, when I get symptoms, it's usually bloating that's related to food. Bloating or constipation, but then it comes down to more of a dietary conversation, if there are any particular foods that trigger. But that's something interesting. I've never thought of that. I said, okay, if there's adhesions, no problem, I'll figure that out. You know, it's the endo stuff we got to worry about.
Right,
that I need to know beforehand.
Yeah. And do you like, well, before, I don't want to miss out on that because Instagram keeps a limit on us. So I don't want to miss out on this conversation because you do it amazing. What do you like? How do you make that choice? What's the difference between shaving and resection, and how do you make that choice? We did a post on it yesterday, but for sure you're going to do a lot better about it.
Right. So when we approach a bowel nodule, there are a couple of things we need to know as surgeons. So one is where on the bowel it is. Two is the length so the dimensions of the nodule, whether it's singular or multiple, and how deep into the bowel it goes. So those are going to help us with our surgical decision making. There's back in the day, or when I was in my residency, and still in some conferences today, you'll see this debate between shaving and bowel resection. So I know there's a group in Paris that does only shaving. So 99% of their cases, they do shaving. So of course, if you've got a very deep nodule and you shave, yeah, you can do it, but you're not kind of removing the disease, you're just giving it a haircut. So it's not gonna do anything for the patient symptom-wise. So for me, it's not about what you're comfortable with, it's what the disease is presenting to you as and what the symptoms are. So shaving should be reserved for nodules that are superficial in their infiltration. So early into the muscularis, or if you want to do a deep shaving, you can go full muscularis, but there is a risk of opening the bowel then. And my personal opinion is that it's easier to do a full thickness disc excision at that time. It's less time consuming and less morbidity for the patient, so quicker recovery. So a disc excision is exactly what it sounds like. So we only remove the full thickness. If you think of the nodule as a circular lesion, so it's running a lap around that lesion and removing it in its entirety. So that it means the outer serosa, the muscularis layer, the submucosa, and the mucosa. And then that defect is either closed with minimally invasive surgery techniques via suture, or it is fed into a circular stapler via a transanal approach, and like a calzone pizza, the anterior wall is stapled to the healthy anterior wall. So it does. So a lot of people have asked me, what happens to the posterior wall? It forms like a little reservoir or a pouch. So this has no difference on the functional outcomes of the bowel. So there's no loss of bowel volume or reservoir of the bowel. And even when you do colorectal resections, if the surgeon does an end to side anastomosis, that also leaves a little redundant pouch there, which has a lot of evidence showing that that doesn't really impact outcomes. So coming to the final method, which is colorectal resection. This is for multiple nodules that are close to each other, or one singular, very large nodule that cannot fit in a circular stapler. So that a circular stapler can accommodate 7 cubic centimeters of volume of tissue. So we can shave and then kind of cheat and fit the rest of the nodule in to achieve a disc excision. But if it's a huge subocclusive nodule where you can't even pass the stapler past the obstruction, you are going to end up doing a segmental resection in those cases, where you literally go just above the disease, just below the disease, remove that segment of bowel, and reanastomose the healthy segments that are remaining.
It's a big procedure. It's time consuming. Much better to be able to do the discoid resection. So we had an interesting comment on the post yesterday, which I had my own answer to, but I'm curious what your answer would be. They had the shaving, and they now have increased frequency of going to the bathroom with I think the number is like 3 or 4 on the Bristol stool chart. So the stool is normal, but they have an increased frequency of going to the bathroom. And the primary care, so don't ask me what I think about that. The primary care said to her, it's because they shaved the bowel and now the bowel doesn't expand and contract. My experience is bowel works totally normal after all these procedures. Is that true?
Yeah, so shaving is a good technique. You mean you have to pick your cases, and it's everybody has different abilities with what they can shave and what they can't. The goal is that you should remove all the disease. So it should be complete no matter what you do. So that being said, it does not really affect the functionality of the bowel, because you're not removing too much of the nerve plexuses. The shaving is the least invasive of all the bowel procedures. That being said, because you will invariably leave a small layer of fibrosis behind, it has a slightly higher rate of recurrences, about 6% for shaving. But that is very difficult to tabulate that data because the methods are so variable. So, but it has the least complications, so especially long-term complications are almost negligible. So I personally don't think that is the cause of that shaving could cause an increased frequency.
Right. So that that whole discussion about it has the least complications. That's why the imaging is so important. That's why pre-surgical planning is so important. So that if you get in there, you know almost before you get there whether you're shaving or you're doing, how you're approaching it, because the patient needs informed consent, but also the surgeons need to prepare. It becomes so important. We talked about poop. Let's talk a little bit about gas. How often do you see excessive gas? And I'm going to talk about SIBO in a minute, but how often do you see excessive gas in the person with bowel endometriosis?
Yeah, very, very often. I mean, that is a lot. There's a lot of distension that occurs. There's a frequency of passing gas, and can also be associated with pain, probably because of the overdistension of the bowel. And I think that, and some patients have also told me that they've not necessarily had flatulence, but they have a lot of belching that occurs as well. So that I don't think I have enough information to collate whether it's got to do with any particular area of the bowel. I think just the presence of disease on the bowel can trigger either symptom.
I feel like the belching and the reflux has something
would be higher up.
Yeah, but I feel like the nerve, so like the hypogastric plexus that gets annoyed from the bowel endometriosis feeds in one way or another to another plexus that causes all that reflux and belching. I'm also going to say in hernia, you get reflux and belching like insane. But the other thing to think about, how much you work with SIBO in India, because I find that small intestinal bacterial overgrowth, that they are, you know, the bowel has good bugs and bad bugs, and that the presence of the adhesions that not only surgery makes, but that endometriosis makes in the gut allows for this this pathology to go on, this SIBO. We're going to have a podcast on it. I'm certainly not an expert, although I have it. And then you really get gas, you really get reflux, you really get either an increase in frequency or you get constipation. And sometimes then that can be traced back to fermentation and things like that. How often do you treat SIBO, or in India, SIBO is like not such a thing?
So I've seen only 2 patients who had SIBO in the last year. And so they were on very specific diets and a lot of antibiotic therapies. So
yeah, I would say 70% of my bowel endometriosis patients, so not just all endometriosis patients, but of the bowel endometriosis patients, have SIBO and don't understand. Like, they have surgery and we take off the endometriosis, and then they still have all these bowel symptoms, and treating the pelvic floor doesn't help because it's all driven by SIBO. And SIBO, I do like, if you've tested positive for it, I do like the antibiotic therapy. I love this doctor in New York that treats it, but there are good SIBO doctors worldwide. And I like something almost like an herbal, antimicrobial, antifungal that the person takes. And then if you're on that SIBO diet, you're going to hate yourself. So you have to find your triggers. Like, I bet it would be horrible in India to have to find your triggers, because for a lot of people it's chickpeas, and there's like right. Unfortunately, for a lot of people, the trigger is wine. One of the good advocates, the trigger is beer. And every time she goes out with her husband, she sends us texts of her going like this at the table because she's so upset. But it you know, SIBO is one that becomes like sort of a lifetime to deal with, and recolonizing the gut in a good way becomes really important. The other thing I learned about fermentation and gas, you can look on our YouTube. It's one of our very first ones with Dr. DeLumba. He's actually standing in a bar while he's on the YouTube. So it was before we were really professional. But he talks about that he went in to do a second look surgery when he was operating in Nigeria, and you could see almost bubbles forming. So when adhesions themselves form, he says it's like if you've ever brewed your own beer or wine and you tap the container and everything like bubbles up. And that he thinks that's why a lot of people have very bad gas with endometriosis, that it's from this process. It's fascinating to watch him. And now he does his own research by visualizing it. I don't have a big randomized controlled study. So it's fascinating to watch that. You guys could check that out. We have another question from the crowd. How often do you see that the bowel pain is that fusion of the uterus to the rectum, which to me, that's a failure to diagnose early enough. And that's all the bowel symptoms, and there is no actual endometriosis on the bowel. How often does that happen to you?
So when the bowel is fused to the back of the uterus, so that is still endometriosis of the bowel, but it's not gone into the bowel. So if you look at the Enzian classification, which we spoke about on the YouTube video, so that is called an A classification of the nodule. So that is on the back, a posterior adenomyoma or adenomyosis of the cervix and or the vagina. And the bowel may just be stuck to it. So once you free that, you may still have to excise the nodule off the back of the cervix. You may need to resect a little bit of the vagina, depending on whether it's infiltrated through the vagina or not. And that's usually great for the patient because it avoids a shaving and you also kind of treat those symptoms instantaneously. But it's the problem is that it may be so subtle, it may just be stuck there. And so I get to view previous footage of patient surgeries, because a lot of doctors give us images or they give video footage of the surgery. So if they do not antivert the uterus, which is make it stand up during surgery, they miss that, because only up there, and the rest of the bowel looks completely normal going into the pouch of Douglas, which is the area right behind the cervix. And the uterosacral ligaments look healthy. It's just that the rectum is stuck literally at the intersection of the uterosacral ligaments. And that is where this tiny nodule is, which can be extremely painful as well. And if this is, and there's no other endometriosis around, this is reported as normal. So, and even if you're looking at the video, as no matter how experienced a surgeon you are, unless you get that kind of exposure to actually look, you're still going to think it's normal. So then the video doesn't become very helpful for you.
Right. So I've been in a lot of ORs in the past few months, and that is a very specific part of the operation that most good specialists will do, where they do that uterine invert. So on your YouTube, I think it's this morning, you talked about post-menopausal endometriosis.
Mm-hmm.
Let's talk about bowel pain in the post-menopausal person with endometriosis. How often do you see that, and how do you choose to work with that patient and help them?
Yeah, so that's really interesting, because I think that's like a little pet project of mine that I'm trying to raise some awareness about as well, and hope to be presenting in Bordeaux this December at the European Endometriosis League. They have a conference. So that is, I want to kind of dispel this myth that even if you remove the uterus and the ovaries and you leave bowel endo behind, the patient is going to continue to be symptomatic and is going to continue to be in pain. So it's not enough to, hope that menopause is going to cure the inadequacies of surgery. One needs to be able to identify all the disease and to be able to take it out as well. Even though you may have identified it and you're saying, okay, I'm putting her in menopause, but that doesn't mean that it's going to shrivel up and die. It can still cause symptoms. So I've got about 7 patients that have been hysterectomized and oophorectomized who required bowel surgery after a couple of years.
We have a good, not as good as that video. I was watching it before I went running this morning, but we have a good video if people still have their access to our endometriosis summit on Endo Summit surgery. Dr. McKenzie talked about what it feels like to have postmenopausal endo, because nobody really believes you. But also Dr. Wasson showed video of that. And it was very good. I would encourage you, if you're interested, to check out Dr. Mangeshikar's YouTube, because his video was actually a little better, to the point where I got to figure out where to put you for Endo Summit this year. So the other thing, I think that it's worth asking you, because we shouldn't assume that you have my same opinion. Do you think things like Lupron and Orlissa help bowel endo?
No, absolutely not. You can't. Not even close. It's so. So when we talk about hormonal therapy, it is only for suppression of symptoms. It's not going to treat disease. So in India, they have a little more leeway. They're not going to get sued as much. But if they, I would imagine in the United States, if they even fathomed or ventured to say that reduces endometriosis lesions by 40%, they would get sued, because there would be no data backing it up. And even the appearance of temporarily reducing lesions is by suppressing estrogen. It causes a reduction in the edema around the lesion, which is not really going to reduce the symptoms or the severity or even the progression of the disease. So the only reason you would give someone hormonal therapy would be to, if you had to delay surgery, if they are unable to come in during a lockdown or a pandemic, or and I personally would use it post-operatively only for adenomyosis cases, or if I've resected a really large ovarian cyst and I just don't want ovulation to occur for 3 to 6 months. And then I leave it to dealer's choice, where I said, okay, whatever you've used before that you're comfortable with, with no side effects, or something that is tolerable, and this is optional, it's not mandatory. So you can go with that for 3 to 6 months, and that's the end of it. So it's not a substitution for removing the disease by any means. It is a suppression of symptoms. That's exactly what it is.
So we do, obviously the Endo Summit does a lot of talk about this because it's an endometriosis topic, but because we have our own opinions and we do carry a bias. But I found what was interesting is we had Dr. Arrington from the Center for Endometriosis Care on once, and he talked about how, birth control and something like Orilissa, it doesn't reduce the edema of the lesion any differently, and there are a lot less side effects, and it's a lot cheaper to do birth control.
Absolutely.
And then I don't know if cameras were rolling, but if you talk about if you're just reducing edema, are you better off on NSAIDs and not putting all that into your system than the Orilissa? And Orilissa, if you look in the footnotes of the studies that helped get it passed, they're really only, I think the longest study is 6 months.
Mm-hmm.
And people who are on it for 2-3 years, after you reduce that initial edema, how much you really doing there becomes kind of scary. But we always get questions about it, I think, because the doctors really push the Orilissa. I'm just going through. Somebody wants to know about what's recovery like between shaving and discoid resection.
Right. Yeah, that's a good question, and it's a very important part of my consults with patients. So, you gotta have full disclosure about risks and complications, and so shaving has the lowest rate of complications, and usually the patient goes home the same evening or the next morning. With a disc excision or a bowel resection, there's the staple line that has to heal, and I would keep the patient back in the hospital until they are able to bowel movement while they're there without difficulty.
That's always so fun as a patient to try to poop, and there's like 78 people waiting for you to poop. And then one of the days I was there for like 8 days, and they got a little antsy, and then they're like pushing the whatever their colace on you, and then you're like not able to go home because you're going too much. It's always like super fun, because also pooping on hospital food is not so easy either. They do that with cardiac patients too. It's like kind of, it's an uncomfortable situation, to say the least. Yeah. So, what is your take-home message about bowel and the shape of poop and the state of endometriosis? We haven't said anything about what's it like to have endometriosis in India, because I'm too U.S. centric. We know that Canada has its own issues with endometriosis care. What's it like to have endometriosis in India, and how many excision surgeons do you really think there are there?
So in India, the good thing is we don't have a referral system necessarily. You don't need to go to primary care to see a specialist. So that's kind of a good thing. The bad thing is that it requires the patients to kind of do their own research and, make their way to, which is great now because social media is out there and a lot of people have access to the internet. We have a huge dichotomy of and then a really uneven distribution of wealth in India. So you've got very rich and you've got very poor, and somewhat of a middle class as well. So for them to be able to afford healthcare, to be able to travel for healthcare, or even to, because especially some of these surgeries is not something I would take on in a smaller hospital. So we have government funded hospitals which are very poorly equipped. I wouldn't do surgery there of this magnitude. So I end up working with a lot of private hospitals that do have availabilities for people who cannot afford treatments. But a lot of patients are intimidated to do that, or they just don't have the correct information to make their way to that kind of referral center or tertiary care.
Yeah,
So,
my dad was in Africa, but he spent some time in the hospitals in India. I think before he was in Africa, and he said like patients would be stacked on the floor because there weren't. But he was in very rural areas because he was doing vaccinations. But he said, you know, and you have to wonder, you know, not everybody is in Mumbai, and even people who aren't in Mumbai are not at huge centers. We learned on Clubhouse that the culture sometimes doesn't support speaking up about painful sex or speaking up about periods. What's it like to practice in that environment? And I know you have that is the importance of your Instagram, is because you're able to expose and have those conversations. But what's that environment like for you?
yeah, so that's really important. And to be one is especially someone younger in OBGYN now, and to kind of put it out there that, you know, this is doctor-patient relationship. There's nothing that is taboo to talk about, and, you know, it's confidential. We're not gonna, so if they come in with their mothers or their mother-in-laws, and I would excuse them to the waiting area while I had the conversation. And so what's really important, what I'm trying to put out there, is that the first way to make the diagnosis a lot better in India is that we are trained not to ask whether a young lady or a patient is sexually active. The first question they ask is, are you married? Which is to find out if they're sexually active or not, which is ridiculous, because that, just based on that, you're going to be able to figure out whether you can perform a vaginal examination or do a vaginal ultrasound. Because if you do an abdominal ultrasound, you're not going to see anything. And very few people do a transrectal ultrasound in non-sexually active girls. And so I think just asking a patient if she or he or they are sexually active when they come in is going to improve the diagnostics a lot. And
I also think, you know, you talked about the mother-in-law, still a lot of arranged marriage in India. And the last person I worked with, the mother-in-law would come to the PT and insist that the pain was because she wasn't happy with the match. And I tried to explain it really had nothing to do with her son. It had more to do with the 6-hour surgery the poor woman had endured. But this is an Instagram. We're close to our hour, and Instagram will shut us off. But we should do this again. We should have a conversation about the taboos in India that may prevent care. Dr. Vidali and I have talked about doing if we're going to do a hybrid, hopefully, so that you'll be able to watch the Endometriosis Summit from anywhere in the world, but doing a reduced rate for what we call developing countries, because we had that with Mexico and Brazil, that they just couldn't, even though we have very low rates, they couldn't afford to go. But now we're really going to establish that so that anyone can get education. I wanted to say thank you very, very much for joining us. How can people reach you?
Oh, thank you. It's my pleasure to be here. And you're such a wonderful, affable host that it makes it really easy to talk about poop and other things poop related. So I'm on endometriosis_India. That is the Instagram handle for the Indian Center for Endometriosis. And also my personal handle, which is basically right now photographs of food and when I used to travel back in the day. And that's it. But I'm available through all social media and whatever you use, WhatsApp, Line.
He's a great
now
YouTube.
on Clubhouse too.
He has a great YouTube for learning.
Yeah.
And I hope next month you'll come back and we'll talk about the like periods in India. We haven't ever done that. We should open that conversation.
Yeah.
It's, you know, it's definitely time. Also, the doctor's on Clubhouse. If you're not already there, he's popped by. So it was pretty awesome.
Yes.
And thank you to everyone. I am going to try to upload this to multiple places, but I'm not always so tech savvy. So I want to thank everybody who joined us, and we'll see you again soon. Bye, everybody.
Thank you, everyone. Good day or good night, wherever you are.